The key words are prevention, treatment, and implementation challenges. I have nothing to declare in relation to this talk. So let's start with prevention. Prevention is the key because there is not much point in treating after the disease has occurred. So prevention can be primordial, where it's the prevention of risk factor development. It can be primary, where the modification of risk factors can be done to prevent the onset of heart failure. And secondary, that's what generally we talk about treatment to reduce recurrent events and progression of the disease. So there are three major aims in heart failure prevention. One, identify modifiable risk factors. Two, risk stratification using novel risk prediction tools. Three, implement effective interventions in the highest risk patients. So this is what I call as ABCs and beyond in prevention and implementation, because there is big overlap. A is the big A: awareness, assessment of risk factors, access to therapy, affordability of therapy, action, adoption, adherence, and artificial intelligence. B for biomarkers, body weight, blood pressure. C for chronic kidney disease, cancer, cigarettes, cardiovascular disease, and cardiac rehabilitation. D for diabetes, dyslipidemia, depression, diet, and digital health. E for exercise, education of doctors and all the stakeholders. F for fluorescence, we heard a beautiful talk, and fasting. And fasting is also coming in a big way. G for GDMT implementation, H for healthy lifestyle, I for inactivity, inertia, influenza vaccination, and lastly, but not the least, influencing, that is social media influencing. It can cut both ways, that for prevention, and also it can be a challenge. So all approaches should be seen in the prism of these six major transitions. This is not exclusive to India. This is happening everywhere, in the city, in the country. So they are economic, nutritional, socio-cultural, environmental, epidemiologic, and demographic. These transitions should be understood. Otherwise, we will not have a preventive program, we will not have an implementation program. So the three P's are prepare, prevent, and protect. In India, it may be patient, physician, and poor. The fundamental thing all stakeholders should understand are the burden of heart failure to the society, coexistence of multiple risk factors, importance of primordial prevention, risk factor optimization, calculators, and interventions to alter the natural history of disease. So coming to treatment, there is a general myth. GDMT in heart failure is very simple. Just give all the four medicines. It is not as simple as it sounds. Actually, we are not succeeding in giving GDMT. So what are the therapies? We all know about it. The Fantastic Four, the first line quadruple therapy, or we all say initiate all four at the earliest, and rapid up titration, or as fast as possible. The additional therapies like ICDs, ivabradine, the other pillars like vericiguat, iron deficiency, and also sleep apnea, atrial fibrillation therapies. It goes on and on and on. So therapies are there and we know about it. But the biggest question is, are we implementing it, or are our patients getting it? So GDMT is grossly underutilized across the world. It is a challenge in the West, it's a challenge in Asia, because in theory and practice are the same. We all think that we are practicing the theory, but in actuality, we are not. This is the CHAM registry. This is a little bit old, but the number of people getting the GDMT was low, and at optimum of the right doses, it was pathetically low. So, like this is 2018, Dr. Green's paper. So, where do we fail, and what are the challenges? The failure is it's coexisting with challenges. Failure to prescribe evidence-based medicine, failure to discontinue medications that may exacerbate heart failure, failure to uptitrate medication to target doses, failure of adherence, failure to address comorbidities, failure to consider device therapies, failure to provide adequate dietary counseling, failure to comply with diet regimen. That's a failure or challenge from the patient point of view. Failure to seek early care with escalating symptoms, failure for adequate discharge planning, failure of adequate follow-up, failure of adequate monitoring, failure of adequate social support systems, and failure to address patient and caregiver needs. These remain challenges. This is a very recent paper, September 2024. And see, we have all the 4 drugs, but if you see here, the majority in US are still not getting GDMT, and red is not prescribed. And we all know that contraindications may be less than 10 to 20%. And what is the reason? And the reason is that the physician believes that patient is clinically stable and or the patient is symptomatically okay. So essentially physician inertia. So that brings us to the question of eligibility and tolerability and the reasons for GDMT non-prescription. Absolute contraindications are very less. And again, the intolerance is something which is people think about it a lot, and recent proven intolerance. And does it preclude from giving therapy? No. Fear of intolerance is very common, and perceived intolerance. And there may be the medical reasons, there may be clinical inertia, the thing that patient is clinically stable, there is no stable heart failure patient, then some people call it heart failure in remission, the patient is stable. And patient reason, patient may be inadequately educated, and systems reason, which includes out of pocket patient cost and availability. We have to narrow the gaps. How do we do that? Identify key factors impacting heart failure outcomes, assess root causes and contributing factors, develop targeted evidence-based interventions, implement comprehensive strategies and solutions, optimize care delivery and patient engagement, achieve improved heart failure outcomes and quality of life. But look at quality of life also. So how do we do that? First and foremost is education. So whom do we educate? We should educate all the stakeholders. We should educate the patient. We should educate the public also. Continuing medical educations, like that's very important. Print materials, mobile phone applications, e-learning platforms and websites, social media and public education initiatives, patient organizations. This is becoming more and more important. Patient advocacy groups should be made partners so that their outlook may be different from a doctor's outlook. Improving guideline-directed medical therapy, country-specific guidelines, very important. And even more important is, in the country-specific guidelines, there should be guidelines for low-resource settings. Implementation strategies, telemedicine, training of caregivers, and multidisciplinary approach. Digital health is something which is coming in a big way. It's already there. And we should leverage that. If you do not leverage, then there is no adequate implementation. And there is no adequate prevention programs also. Now let me shift gears and move on to India. So India is a very populous country, and heart failure is the leading cause of mortality and morbidity both in rural and urban India. And the number of people affected, the number varies, the statistics varies from 22 million to 40 million people. And importantly, in-hospital mortality and one-year mortality are significantly higher compared to high-income countries, and it affects the younger people more. And out-of-pocket costs are high, hospitalization costs are high. The challenges and possible solutions of heart failure care in India, one is that heart failure therapy is resource intensive, ICU care is costly, and you need lifelong therapy. Devices like ICD, CRT are mostly unaffordable. Vast majority even now spend out of pocket. Public hospitals with facilities are limited and overloaded. Possible solutions include control of drug prices and generic drugs. India has been called the generic drug capital of the world. subsidy and financial assistance for prolonged drug therapy, medical insurance, state government as well as central government. That is the way forward. So let me share with you some of the approaches from our country. And one is registries. You may wonder what is registry to do with implementation. These are two registries, both of them led by Dr. Harikrishnan. And over a 5-year period, GDMT improved from 24% to nearly 46%. So people started prescribing more. So registry did its job. And people who had GDMT, who continued GDMT, there was a significant difference in mortality. And mortality is the hardest endpoint. It's not a combined. You can see cumulative mortality in both registries. People who follow GDMT, significant difference. India has the world's largest government-sponsored healthcare program. Free access to health insurance for low-income earners. And it may benefit nearly 50 million people. And once it reaches fruition and proper maturity, there will be huge amount of beneficiaries. In India, the heart failure is state subject. And what does my home state do? All the government institutions have screening, treatment, and follow-up for hypertension, diabetes, and cancer. And more interestingly, all have lifestyle modification counseling. And in 5 years, nearly 59 lakh hypertensives and the newer data is about 50 lakh diabetics have been picked up. And ladies and gentlemen, that is the first step of prevention. Artificial intelligence is important and the collaboration is the key. It is just not doctors alone. We have to collaborate with the time of technology. And Cardiac in India is a collaborative attempt. It's a consortium where the central government, the medical research institutions, technology research institutions, and technology companies have come together. And we are trying to make as national CVD cohort with personal health records, non-invasive novel signals, digital phenotyping, and multi-omics. And AI can predict risk factors, predict morbidity, and also maybe predict treatment. Heart failure therapy is a team game. It is soccer or football. It is not cardiologist-centric. We need from cardiologist to nurse to nephrologist to emergency care specialist to pharmacist to home care to palliative care to social worker. And if you miss, then it is like playing soccer without a key player. So this is how the heart failure clinics in my institution is structured. For stage A and B heart failure, there is what is called as cardio-renal metabolic clinic. So they are mostly into prevention and identification of risk factors. Stage C heart failure, we have the HOPE clinic or heart function optimization and evaluation clinic. And there the stage C or the majority of the heart failure as we perceive are treated. And the top of the pyramid is advanced heart failure clinic, where stage D, where devices, CRTs, transplants, LVADs are done. So, ladies and gentlemen, this is my last slide and my most important slide. What is Heart Failure Association of India doing? And so what we are trying to do is having a series of the heart failure clinics. It is facilitated by the nurse, doctor-led, at least one per district, at least 1,000 heart failure clinics across the country, where there's real-time data entry and treatment modification. This is our moonshot. What is a moonshot? It is a plan or aim to do something that seems almost impossible. We hope to reduce heart failure mortality by at least 10% in 10 years. Ladies and gentlemen, I thank you with this quote. Great science alone will not save lives. For that, we need effective implementation. Thank you very much for patient hearing.